is Gustavo Vinagre and I'm here to talk to you about shoulder radiology. So, we're going to see some shoulder radiological views, the AP view, the true Gracie AP or near glenoid view, the shoulder with rotations, the subacromial view, the PA oblique in Y or transscapular view, the axillary view, the axial view, the West Point, the striker notch view, and the glenoid profile or Bernard jaw. So let's move on. Here you can see an AP view. It's a view to get an overall impression of the shoulder. You can see the clavicle, you can see the coracoid, you can see the spine of the scapula, you can see the acromion, you can see the humeral head, the anatomic neck, the greater tuberosity, the lesser tuberosity, and the surgical neck, as well as the scapula. So, which is the difference between this view and the AP view? This one, as you can see, you have all the line in the glenohumeral joint. And when you do an AP view, you don't see as well the glenoid, okay? Because it's like a frontal view, and when you do it in 45 degrees, you can be parallel to the glenoid, so you see all this line. We can see a shoulder with rotations, with external rotation and internal rotation. It's very useful to see the greater tuberosity, and if you have some problems in the fractures, you can see it better. Okay. The subacromial view, you can do it in the frontal subacromial view or the lateral subacromial view. So here you can see all the subacromial impingement syndrome, and you can see some dislocations, some fractures. Okay, so it's very useful, this one. The PA oblique in Y or transscapular, it's a view where you can see all the scapula, so it's very useful in some scapular fractures. You have to ask the patient to get his hand on the buttock or on the back to see all the scapula, and here you can see the another possibility. Okay, so the Velpo view, when you have a patient on a sling and you have some fractures, you want to evaluate the patient, you ask him to lie back on 45 degrees, and you can do this view. The axillary view is you have to ask the patient to abduct his arm on 90 degrees, and you do like the x-ray in the axillar. So you see all the glenoid, you can view some Bankert lesions, some anterior Bankert or posterior Bankert. It's very useful. And the axial view, you have to ask the patient to external rotate his shoulder, and you do a frontal view, so you can see all the back of the humeral head. So it's very useful to the heel sach lesion. The West Point view, here the patient is lie on the cubitus position, so you can see all the glenoid. So it's very useful to see some Bankert lesions too in chronic instability. The striker notch view is a view where the patient is laying down, and you have to ask him to intervert his shoulder. So as you can see here, you see all the back part of the humeral head, so you can see the heel sach lesion. Okay, as well as the axial view. And this one is the glenoid profile or Bernard jaw view. Here you ask the patient to be in this position. If he is too tall, he has to bend his knee and be on and bear his knees and there on his knees. So here you can see all the humeral head. So you can see a heel sach lesion as well as a Bankert. Okay, so it's the best one for instability. When you want some specific, let's do some review of these radiological views. The AP view is the most common one, is when you want to get an overall impression of the shoulder. Okay, the Gracie or true AP view or near is to see the glenohumeral joint. When you do an axillary view, you want to see some banker lesions and some bone banker lesions, as well as the West Point view. The Rockwood or the lateral, the frontal subacromial view, as well as the lateral or supraspinatus outlet view, is to view all the subacromial space and all the subacromial impingement syndrome, okay? And the striker notch is to see the heel sach lesions as well as the axial view. So when you want to get an overall impression of the shoulder, you do an AP or a true Grashey AP view. When you have a patient with a subacromial impingement syndrome, for example, in an older patient, you want to make an AP or you want to make some subacromial views, the front or in lateral, or instead of the lateral one, you can do the PA oblique in Y or transcap. When you have some fractures, you view, and you can do it with some, for example, external rotation to see the greater tuberosity. And you can do a lateral subacromial outlet or PA oblique. You can choose one of both. And you can do when the patient is in a sling, you can do the Velpo view. If a patient have an acute dislocation, you want to see if it's anterior dislocation or posterior dislocation, you do a lateral subacromial outlet or a PA oblique, a transcap. When you want to see some problems with chronic instability, some dislocation complications with a patient that had some dislocation, you can do an axillar view or a West Point view to see the banker lesions. You can do an axial or a striker notch view to see the heel sach, and you can do the glenoid profile Bernard Joe to see both. So it's the best one to see because you can see the heel sach lesions and the banker. So let's move on to the AC joint. Here is the AC AP view. You see all the acromioclavicle joint. So if you put the patient, if he had some dislocation and you want to see the AC joint, you can put the patient with some weight, and it can exaggerate all the dislocation. And the Zenka view is very useful too for the AC joint dislocations, because it's when you do the X-ray with 10 degrees of cephalic tilt, so it's very useful. And the MRI is a conventional MRI. It's very useful, very done. So here you can see all the muscles, the tendons. So you see the supraspinatus upwards, the subscap on the front, the glenoid fossa, the articular cartilage, the head of the humeral head, the greater tuberosity, the lesser tuberosity, acromion process, clavicle, coracoid process, deltoid, infraspinatus, the head of the scapula, and you can see some interarticulary problems too. So it's a very common and very useful exam. You can do an MRA. This difference between the MRI is that you get contrast inside the joint, so you have to inject contrast inside. So you can see all the interarticular pathology. You can see, as you can see here, we see some labral banker lesions on the front, on an anterior banker labral lesion. But it's very useful, but you have to get some contrast inside the joint. And the Ahrtro-CT is like a CT scan with contrast inside the joint. So when you have some contraindications in the MRI, such as some claustrophobia or a pacemaker or an electronic device or whatever, you have to inject contrast inside the joint. And as you can see here, it's very useful too when you have some shoulder anchors, okay, of, I don't know, instability or rotator cuff pathology. And it's very useful too for some calcifications And as you can see here we can see a frozen shoulder because the contrast is only on the anterior part of the joint. It's not on the posterior part, so it's a frozen shoulder. And it's more cheap than the MRI or the MRA, and it can be very useful too. Okay, so I hope you liked the presentation. We have finished yet, so I hope you like it. I hope it is useful for your daily practice, and see you on the next presentation. Bye bye.